Good evening, sir.
So should we just dive in and start because it's 8:01 before we, since we have everybody here.
Start.
Okay. A very good evening and a warm welcome to everyone who's present here. This evening, I welcome you all for a joint session by the Women Psychological Health Committee of the Indian Psychiatry Society West Zonal Branch, along with the Association of Surgeons Nagpur, for an engaging panel discussion on Psycho-Oncology interface, where we would be focusing on cancers in women and the psychological impacts as well as the management part of the psychiatric disorders associated. For this, I just want to welcome all the IPS West Zonal Branch office bearers, especially our president, Dr. Neena Sawan ma'am, for being here with us, along with Dr. Sudhir Bhave sir, who's the vice president, and who's also graciously agreed to be the chairperson for the event today. We also have the advisor for our committee, Dr. Meenakshi Parikh ma'am with us right now, as well as the president of the Associations of Surgeons of Nagpur, Dr. Prachi Mahajan ma'am, who is also going to be one of our esteemed panelists. Without wasting further time, because we have a short time with us and we have an engaging discussion onwards, may I now take this opportunity to introduce our chairperson, although I'm sure both in the psychiatry field and all the people in Nagpur really don't need me to introduce our chairperson, Dr. Sudhir Bhave sir. He's a renowned name in the city, the professor of Department of Psychiatry at NKP Salve, Nagpur, with a vast experience of 36 years in the teaching field. He's a postgraduate guide and examiner and has been topper in almost all exams in his school and college years. He has recently received the Lifetime Achievement Award by the Bombay Psychiatry Society last year and has been the winner of the LP Shah Orishan Award in 2020, as well as the Nagpur Bhushan Award in 2003. He is the member of the National Executive. He's a National Executive Committee member at the IPS national level, and he has published multiple papers in index journals and authored several books, as well as edited the first book in the world on cyber psychiatry for the Indian Psychiatry Society. Besides psychiatry, sir's another passion is music, and he's an acclaimed light music vocalist who has cut an album of his songs in 2010. May I request you, sir, to now introduce the panelists for the evening so that we can take the program further.
Sure. Thank you, Abha. So, can I get the slides? Yeah. Dr. Prachi Mahajan, it has been a great pleasure to be associated with Prachi for the past many decades since she is from Nagpur.
My privilege.
Oh, thanks. She did her MS from Mumbai, FRCS UK, fellowships in advanced laparoscopy and bariatric surgery, and has extensive experience in breast cancer surgery, GI and laparoscopic surgeries in the past 21 years in Nagpur. So I think that makes her a very apt speaker for this seminar on psycho-oncology. Bariatric surgeries and diagnostic endoscopies are her areas of interest, and she has been a recipient of some prestigious awards for her work in GI surgery, actively involved in breast cancer awareness, obesity awareness, and other health awareness initiatives. She happens to be the incumbent president of the Association of Surgeons of Nagpur and has been a faculty at major national and international surgical conferences. And I must say, I'm a witness to her passions like theatre acting, which we have seen amply in IIM Nagpur, her writing, her fitness. I was a close witness to her being a quiz master in various quizzes that she has conducted. A quiz master requires a vast knowledge and
Hello.
Hello.
हाँ बोलो.
Am I audible?
Yes, sir. Yes.
Yeah. So,
मिडल गेट पे, मेन गेट पे कहाँ खड़े रहने देते हैं?
unmute myself. Yeah. So I was saying that I have seen her conduct many quizzes in Nagpur. I mean, her eloquence, her vast knowledge in the field, I think they have always been very impressive for all of us here. So that's Dr. Prachi Mahajan. So could we have the next slide? Yeah. Dr. Jayata Devdhar is the name in psycho-oncology in the country. And we know her as the psychiatrist working in the field at the Tata Memorial Hospital for I don't know how many decades. She happens to be in the board of directors of International Psycho-Oncology Society, editorial board of Psycho-Oncology Journal, and Indian Journal of Palliative Care. She is a Central Council member of the West Zone of IAPC, several publications and presentations which we psychiatrists are very well aware of. And as you can see, all her areas of research interest and clinical interest happen to be in the field of psycho-oncology. So welcome, Dr. Jayata. And yeah, the third panelist for the day is Dr. Tanushree Jain, who is a senior consultant gynecologic oncology. Now, this gynecologic oncology is a relatively new field, and I mean, when I was going through her CV, I mean, when there were many things which I got acquainted with for the first time. She works at the National Cancer Institute, a very state-of-the-art institute in Nagpur. Had her education in KEM Hospital and MCH from Tata Memorial Hospital, Mumbai. And I think one thing that I found very impressive was that she is the first MCH gynecologic oncologist in the country and has international fellowships in laparoscopic and robotic gynecologic oncological surgeries. Has done fellowship from Seoul, South Korea. An experience of more than 15 years in gynecologic oncology, special expertise in performing cytoreductive surgeries, credited with performing the first CRS and HIPEC in Central India, again, I would say major achievement, and has special expertise in peritoneal surface malignancies, minimally invasive oncologic surgeries, and oncofertility. Again, a term that I heard for the first time, oncofertility. And her earlier appointments, as you can see, have been at very prestigious institutions. So welcome, Dr. Tanushree.
Thank you. Thank you so much.
Yeah. So that, do I hand over the proceedings to Abha? Abha, you are mute.
Pardon me on that. Thank you so much, sir, for giving such a good introduction to all our panelists and setting the context. Like you mentioned, there were a lot of newer terms that we heard today. And as practicing general adult psychiatry, most of us seeing those patients, a lot of time the patients with special needs come to us. And these webinars are centered around updating our knowledge on the same. So with that in mind, my first question is directed towards Prachi Mahajan ma'am. May I request ma'am to unmute yourself? Yeah. So recently, we keep hearing more about women being diagnosed with CA breast. Is it a true increase in the incidence of the illness, or is it because of more awareness? And are there other deterrents which might hamper the faster diagnosis and screening?
Yeah, that's a very good question, Abha. And the incidence of breast cancer has actually increased multiple fold than what it was maybe a couple of decades ago. Of course, the awareness has also increased. So that is, and we have a lot of important diagnostic tools. So because of those, we are able to actually pick up these early malignancies also. So that is another aspect. I think we'll discuss that further down. But yes, the incidence has actually increased. If you ask me the reason for it, we know that cancer, especially breast cancer, it could be a hereditary, that is a genetic condition, or an acquired condition because of many hormonal influences, and that results from our, so to say, unhealthy lifestyle. So now that we are seeing late marriages, less number of children, I mean, what was described in our textbooks was, uh, not having children, or no lactation, that is, breastfeeding was not done. All these are predisposing factors for breast cancer. And all of these lifestyle factors are very much in vogue today. Now, there is no scientific evidence to prove that this is this, because of this, the incidence has increased. But I'm sure that it does have a contribution to the increase. And of course, we have a lot of chemical agents in our diet and lots of environmental pollutants, which could be responsible for the incidence of breast cancer. So if you ask me the deterrents for, which cause late detection of breast cancer in most cases, I would say it is mostly ignorance.
Okay.
And so, if you talk about the psychological aspect, every woman wants to ensure that her family does not feel the pinch and does not get burdened because of her health issues. And that is the main reason, especially middle-aged women never come up early in the early stages. They know that they have something which is very suspicious because they present to us when it has become overt, and in most cases it has become advanced. So it is partly ignorance and partly willful ignorance on their part. So that is the most important reason. And mostly, while we were discussing this, I did touch upon alternative medicine. People love to run to practitioners of homeopathy or Ayurveda and want to resort to some, non-scientific things, as well as they gain a lot of knowledge, try to, of course, get some learnings from Google and Wikipedia and so on, and they just try to convince themselves that it is nothing serious. So I think these are the factors.
Yes, ma'am. Dr. Tanushree Jain, would you agree that it is the similar factors when it comes to other gynecological cancers? Would it be the similar factors, and is the incidence also increasing there? And here I would also like to touch a little bit upon oncofertility. Is the fertility, like ma'am mentioned, because of later age of childbirth and delivering, does that also have an impact and on the fertility and gynecological cancers?
So yes, as Dr. Prachi ma'am rightly pointed out, that definitely we are seeing an increased incidence of gynecological cancers and of course breast as well. And the two main reasons I would say is the changing lifestyle, and the other is the changing socio-economic status of our female. So definitely delayed childbearing has become a norm today. So all these factors, and again obesity is a very common risk factor, and in fact it is a risk factor for breast as well as uterus, endometrium, and hypertension, diabetes. And as the risk factors will increase in our population, definitely the sequelae, particularly the cancer, is definitely going to increase. Although we will see the effects in later life, in later decades, but yes, the risk factors have definitely increased. Of course, she already pointed out the other factors, but apart from that, one more thing that I see is awareness is definitely not there, particularly in our country. But other thing is these organs, the problems related to these organs, our patients are not so vocal about them. And particularly these are elderly patients, so they are afraid to tell their son or daughter about their bleeding problems, about their discharge problems, about their lumps in breast. So that is also one of the reasons that they hide it, because they feel they are ashamed to be to say about them. So that is one thing. You asked me about oncofertility. So it's a term coined around, I think, around 3 decades back, and it's a specialty that looks towards the fertility aspects related to cancer patients and their survivorship, in simplified terms. So per se, the scope of oncofertility starts before the treatment starts of the patient, because here and we try to protect our patient from the deleterious effects of cancer on fertility, and at the same time also the deleterious effects of treatment per se on their fertility.
Right.
And then it lasts along with their survivorship, their follow-up and all. So the scope is vast, and day by day it is increasing.
Okay.
And it is now, there are strict guidelines about protection of fertility in these patients whenever they are undergoing any kind of cancer treatment.
Okay.
So, but the awareness even among the clinicians is less. So we need to start thinking about it before the treatment starts. So that is something very important.
Okay. Joyita ma'am, like Tanushree ma'am just pointed out, there's a lot of stigma around talking about the symptoms and anything, about even the treatments probably. But if I talk about specific psychiatric disorders that are more common in patients diagnosed with cancer, are there some unique features? Are there features that are unique to women? Are there some diagnoses only seen in women, or do they deal with it in a different way than men do?
Right. Thank you. Thank you, Dr. Rabha. And it is so nice listening to Dr. Prachi and Dr. Tanushree. So I'm going to talk about breast cancer because that's the major part and that's the number one. Although women with gynecological malignancies will see a lot of ovarian, endometrial, and mainly and cervical cancers, of course. And there are certain commonalities, but there are a lot of differences between these two groups of women, and also a lot of the age differences, how it counts about. So about psychological issues, I'm going to talk about psychological issues separate from psychiatric disorders, because when we were talking in oncology, we are not doing sort of general hospital psychiatry. We are talking about that and with women's cancers. So obviously, everybody with cancer will not have a disorder, but they may go through grades of distress. And so for cancers in general, what we see is distress, a little more, and this distress could be mild, moderate, severe. If it is moderate, severe, then it will probably be anxiety, depressive symptoms, or then go on to anxiety disorder or depressive disorder. But if you see amongst women, definitely anxiety seems to be more common than depression overall in women with cancer. Except for breast cancer, wherein it is the third cause for depression after head and neck and pancreatic cancer. Breast cancer is the third cancer associated with depression. But if you see literature, it's mainly anxiety. In breast cancer, it's around about 10 to 30%. I'm not saying disorder, I'm saying symptoms. If you see about literature, it said that if you go by structured diagnostic criteria, it will be about 10% in oncological settings, palliative care settings, hematolymphoid malignancy settings, rates of anxiety. For depression, according to structured diagnostic criteria, it will be about 15% or so. But distress is something which is more common, sort of it's an unpleasant subjective sensation, having emotional, cognitive, psychological issues. That is about 1 in 3. And of course, you will see all the spectrum in women with cancers, breast cancers. Sometimes I feel we know a lot more about breast cancers because that's been like really, really studied, and most of the literature is that. And a lot of the gynecological malignancies, more and more studies are coming and saying about how many symptoms, what symptoms, psychological issues that they have. So the psychiatric disorders can be from that if some people have more severe ones, but these are the psychological issues, and those are going to be the response, the anxiety and treatment trajectory, and what is the social support. All these will count to that because those will be the risk factors. As far as differences between men and women, we know that in psychiatry, most depression is going to be commoner in women. But in cancer overall, it seems to even out. It's sort of equal, men and women. Only difference is that where does it begin? So women may be expressing it or having symptoms more at the beginning, whereas men may be having it more later on, towards the latter part of their disease trajectory. The other thing that matters is their coping styles. So the women try to cope. The men think that they are coping, but they might have worse outcomes, and we cannot really sort of see exact gender differences because a lot of it is that biology differs. Biology, not because of the psychiatric disorder and the family history, etc. Biology for the cancer itself, and cancer basically is sort of an inflammatory state. And if it's an inflammatory state, that means it's neuroinflammation. That means depression is going to be more common. So can you relate all that? So that becomes a general thing. So we can't really say that, oh, men with prostate cancer will have less depression than women with breast cancer and ovarian cancer. It's just about the, it's just about the journey and all these other factors, the predisposing factors, the precipitating factors, the perpetuating factors, which are common for all psychiatric disorders. So
yes, ma'am. So I think that goes, like you said, common for all psychiatric disorder. But having said that, this question is to Prachi ma'am, because in CA breast, a lot of time as part of treatment, we may have to remove the breasts. So there is a lot of association, and for women, that image or the femininity is associated with the breasts as part of it. So how does that affect their psyche, or does that make an impact in decision making treatment wise? And also, because like ma'am just pointed out, CA breast is something that we've heard about a lot more than gynecological cancers. So do the first degree relatives, do the first degree female relatives get a little more scared about the whole thing? And how do we counsel them then? So in your day-to-day practice? Yeah.
So, there are various aspects which determine the type of response and their own thoughts about their self-image or their body image, so to say.
Right.
Now, of course, I mean, one thing is very clear, that breast conservation is possible only in early stage breast cancer.
Right.
So, that is a point which is underscored every time. And now, if a patient has an operable breast cancer, the decision, it is as surgeons, it is our duty to explain, that these options are available. If it's an operable breast cancer, we have to give them an option that you might undergo a mastectomy or a breast conservation surgery. In case a mastectomy is done, reconstructive procedures can still be performed. Right? So the decision, I mean, it is, as doctors, it is our duty to explain the options. But usually it is my practice to leave the decision to the patients. Now, if you talk about the population in Nagpur or Vidarbha, or the patients which are coming from the city, I would again categorize into age groups. Usually the middle-aged patients, especially 40 plus, they just say that, nikal do pura. We don't want to keep any problem, anything which might be dangerous in the future. And most of the patients, because I had presented this work, comparison of mastectomy and breast cancer surgery in Vidarbha in the National Surgeons Conference last year, and again at Ahmedabad at the Association of Breast Surgeons of India. So this is a topic which is close to my heart, because I had actually conducted a Google survey. I had circulated Google forms amongst all my operated patients regarding the level of satisfaction patients have following a mastectomy. So the findings were that those who had undergone mastectomy, or those who had opted for mastectomy, were quite happy with their decision. They never regretted not having a breast conservation or a reconstructive surgery. And those who had opted for breast conservation were equally happy with their own decision. So, at least if you consider practice in Nagpur or the neighboring areas, people are more happy, or they opt for a mastectomy, that is a radical surgery, in larger numbers than, I would say, urban population. In younger patients, usually, if it's an early breast cancer, I would myself, counsel in such a way that wherever possible, it is better to conserve the breast. And with newer molecular diagnostic techniques, even the adjuvant treatment has become simpler and more tolerable and more targeted. So, in general, this question of body image, I think it's more up to the patient's acceptance. But in younger patients, I tend to push a patient, at least, of course, the decision is their own. And so many times, even for smaller lumps, people just opt for a mastectomy. So, of course, I mean, it is very true that the body image depends upon the breast. And then we have reconstructive surgeries. We have external prostheses also, which are very good. So, overall, I think our women are more resilient than men, and women have accepted the situation the way it is.
Okay, ma'am. Thank you. Tanushree ma'am, like for CA breast, ma'am just said we have a lot of options, whether it's reconstruction, whether it's external implants. But when it comes to gynecological cancers and when the fertility issue comes in, or again, the image of whether I will be able to perform, satisfy the sexual needs of my partner, myself, or otherwise. Again, how does that play in the psyche of treatment option choosing, or being compliant with the treatment, or how do you think that affects your clients when they come to you?
So, as you rightly said, the reproductive organ per se is affected in my patients. So
Right.
yes, surgery is going to affect it. But probably what happens is now, there is a lot of counseling required, because first of all, I'll just enumerate how fertility is affected in my patients because of the various aspects. So
Yeah.
first, if I'm talking about surgery, yes, the organ will be removed. It may or may not be. Just for timing, I'll say may or may not be, because today we have so many options, and per se, patient doesn't know only. When we talk about that, then they come to know that, oh, this is possible. Again, they are not aware about the side effects, like they will lose their hormonal function and everything. It might affect their sexual function. So that all comes into play later when they are some way cured. Then they start thinking about it. So herein, our role is important that we tell them beforehand that yes, this is possible. This is not going to affect your oncological outcome. Your survival is going to be similar. And then we plan a treatment for them. So per se, our treatment protocol depends upon the patient profile as well as the tumor profile. So here an age, desire of patient from her future, and her fertility concerns all are taken into consideration, and then we make a tailored protocol for the patient. So that is for surgery part. Again, even chemotherapy and radiation is going to affect the fertility of the patient, because chemotherapy drugs are many times gonadotoxic. They are going to affect her ovarian function. So here and we have to tell them that yes, you can preserve your eggs, your embryos, or even a part of ovary, so as we can reimplant them later once their chemotherapy part is over. So that part has also to be discussed and thought about prior to the treatment onset. And again, the third thing is radiation. So as low as, if you see radiation, we give 50 gray. So 2 gray can just destroy her ovary. So, and for any cancer, so not for the reproductive organ. So here and we have to see and decide about that. Okay, agar ovaries are, then we may need to remove them and put it at a different site. So all this has to be taken into consideration. And as you said, sexual dysfunction is definitely common because of hormonal imbalance, because of some local or mechanical factors like radiation given to the genital organs, and then that sexual dysfunction is affected. Thirdly, they have negative body image. Even removal of uterus puts that kind of pressure on them, that now I'm not a normal person. I will not be able to lead a normal life. So all this has to be counseled to the patient. They talk with us. Frankly, they are, when we tell them, they are more open to it. They speak out. They ask us, okay, is it possible for me? Then we have rehabilitation like vaginal dilators and many, creams and all. So that is ongoing process. So it's not a one-time thing. They need support throughout their survivorship. So I think that is very important for our patients.
Right. So basically, counseling right at the time of diagnosis, throughout treatment, and hand-holding them throughout is very important. Rita ma'am, when do you think is a time that patients need to be referred to psychiatrist? Of course, because a lot of times patients might be reluctant to add on a specialist to their treatment. They might have a better rapport with their oncologist. And in case patients do come to psychiatrists, are the treatment recommendations, let's say for depression and anxiety, any different from our general adult psychiatry patients without cancers?
Right. So there are two things for your question, two things, and I do need to come back to what Dr. Prachi and Dr. Tanushree said about the patients, because anyway, I'll come back to that later.
Yes.
So when do you have to refer to psychiatry? So the whole thing is that there is anyways with mental disorders, there's so much of stigma, and then cancer patients, and then you refer them to psychology, psychiatry. Obviously people don't like it, so we need to sort of integrate psychosocial bits into routine cancer care. Now that is ideal. That is absolutely ideal when you have the people, when you have the resources, when you have the settings, which we don't. And when do we refer? So the ideal thing would be at every point, actually, because it's a journey. So at the time of initial screening, that doesn't mean that somebody who's screened is all okay now will be okay later on, during treatment, post-surgery, after that, during follow-up, between next chemotherapy cycles, or at recurrence, etc. So at critical points in the journey, I think we need to really screen. And I know it is not ideal, but different settings can sort of do some things to get that. You know, they have good rapport with the nurses, good rapport with some of the data coordinators which are there. But nurses are, I think, are a very integral part of psychosocial oncology. So ideally, we should be doing the screening in some form or the other. The thing is about psychiatry referral is we really need to know the family history, a pre-existent psychiatric disorder, because those are ongoing risk factors. Those, even if they didn't have cancer, those would be risk factors any which way. So some way, I think we have to incorporate that into the screening. And many people will not tell us that they are, you know, I have so many patients who have had schizophrenia. Now they've had a lump, and it's always a late diagnosis because anyway, women will not talk, and women with schizophrenia will not say that, right? And we don't have screening programs for them. So they wouldn't. So we need to know about, it only comes up during anesthesia screening that, oh, there is some disorder, and oh, we posted tomorrow, and oh, will you please come and see? And there are 10 other medications that's going on, one of which will be clozapine, and we are dead. But you know, so there has to be some mindfulness into when to refer and who to refer. And since we are talking in interdisciplinary, multidisciplinary thing, I think we need to normalize this. You know, there should not be, a lot of the stigma comes from the professionals. And if the professionals are normalizing, it doesn't really matter for a lot of it, not the ones who are sitting here, obviously not, they wouldn't be in this, but you know, and it sort of happens imperceptibly. So that is a constant battle against us. But so that way, that's why some kind of a screening process, some kind of pre-existing psychiatric disorder, you know, already anxiety, taking some medications, we need to know that. I'm telling you very, very basic things that we really need to know. Coping strategies, all that is fine, but we're not in an ideal setting. Even if you are in a private practice, you still are very busy. We still are not going to be able to give more than 20 minutes, max to max 30 minutes for all this. Cannot be done. And in Tata Hospital, everybody knows, we like, you know, if you don't have that turnover, the next patient will be waiting, and we'll all be waiting till then. So we need to find out our own resources and find out how best to modify to our patients' needs. Ideal is fine, but we all have to work in resource constrained settings and make our own plan. So that's a personally tailored plan for our own patients. For management, for treatment, this is very important for psychiatrists to know. Is that we are all very good of depression, anxiety, bipolar disorder, anxiety disorder, SSRIs, or this, that is it. We can't be. We are here for psychiatry, which is mental health, which is psychology and psychiatry. So our approach is our biological, psychological, social, and environmental. This is not a thing for just giving the medicine and that is going to be it. Sometimes it is not going to be medicine. So we have to be, as psychiatrists, happy with that, oh, I don't have to give the medicines. I need to spend some time and do this part of psychosupportive psychotherapy or cognitive behavioral therapy, etc. But moderate to severe symptoms of either anxiety, depression, pre-existing disorder, that we have to give. But moderate to severe symptoms, we have to get in the medications. Then that needs a lot of liaison with the oncologists and doing that, but we should not shy away from that, because ultimately, what is our aim? Our aim is improving quality of life. The biological treatments will help, the medical, surgical treatments will help, but this is our bit to it. So we should not really hesitate. We find the one which is best suited for the patient, previous response, what are the medications, etc. But we should not shy away from giving the antidepressant medications, bust the myths, and not addictive, and all that goes hand in hand that way. And anybody who's taking previously medications for schizophrenia, bipolar disorder, he cannot really stop it. We can modify, optimize, change a bit, etc. But it's very important to take care, because then you're dealing with two things together. So if you're dealing with two things, we have to work hand in hand with that. Especially for breast cancer and sometimes for ovarian cancer, for the hormone positive cancers, is when we are using tamoxifen, that is when we need to be very careful of our antidepressant medications, because tamoxifen has to get modified to metabolized to endoxifen, and anything that stops the process, which is our CYP2D6 inhibitors like paroxetine, fluoxetine, to some extent citalopram, escitalopram, all those will affect that. So very important, and this, otherwise we will not know. People who are on tamoxifen, and it's not just breast cancer patients, ovarian cancer patients can also be on tamoxifen. We need to, because it's a SERM, we have to avoid the CYP2D6 inhibitors and use the ones which are least inhibitor, which is mainly mirtazapine or desvenlafaxine. That is something very important for everybody to know.
Okay, thank you so much, ma'am, for elaborately covering the whole thing. My last question for Prachi, ma'am, before we take questions from the audience, is with the advent of newer treatments, how has the prognosis over the years improved? What is the hope that we can give to patients of breast cancer, and how heritable it is? How important it is to counsel patients' relatives, female relatives, about it?
So, breast self-examination versus all the modern diagnostic tools. It is always breast self-examination, which is the most important diagnostic tool for self-examination and self-diagnosis. Now, we have very good quality digital mammograms these days. So they can pick up very, very small lesions. In case of doubtful lesions, the gold standard is MRI. So an MRI of the breast, irrespective of the composition of the breast, whether it is glandular predominant or fat predominant, it will give you a very good differentiation and a very good diagnosis. So that is as far as the diagnosis is concerned. Again, initially, in years gone by, we used to rely on FNAC, but nowadays we don't treat a patient based on just the FNAC. A histopathology, that is a core biopsy, is the investigation of choice, and that is what we consider before starting any kind of treatment. Of course, when we do the staging with PET scan and everything, and we know that it is an operable cancer or an inoperable cancer, the targeted therapies are very, very important. So when we do a histopathology and we get the specimen, the sample is of course subjected to ERPR and HER2/neu, that is the receptor studies, the hormones are studied, and the hormone receptor status. And we have very good prognostication also nowadays. So we have an array of genetic tests which will give us good prognostication in any patient. So we are in a better position to advise the patient regarding the future of oncological aspects as far as the future trends are concerned. And accordingly, because even chemotherapy, as I've said, when we were students or when we were surgical residents, any node positive patient used to be subjected to chemotherapy, but that is not the case anymore. Nowadays we have excellent advances in the field of adjuvant therapy as well as surgical therapy, and all the endocrine aspects. And I must thank Dr. Devdar for that tip on tamoxifen. That is really invaluable for surgeons also to know. So with all the newer diagnostic techniques as well as breast conservation and oncoplastic techniques, which give excellent aesthetic results. So the prognosis has definitely improved, and we have a higher survival rate, 5-year, 10-year, and 20-year survival rate. Of course, obviously, it depends upon the grade and the tumor characteristics. So the tumor biology, and we have so many, even more sophisticated prognosticated factors such as oncotype DX and all those. So even patients who have a low index can just skip chemotherapy. And I must say that most patients are scared of chemotherapy rather than surgery. So it is the fear of the side effects of chemotherapy which prevent the patients from seeking medical help in the first place. So we must counsel and create more awareness regarding this, that with targeted therapies, even there are patients in whom chemotherapy is really not required. So that way, life is become better for cancer survivors. As far as hereditary factors are concerned, fortunately, they are rare, at least in India. But we do have families of breast cancer patients. And in such cases, of course, genetic studies have to be done, BRCA1, BRCA2, have to be checked in families where, there are sisters or mothers and daughters who have been patients. But the incidence is fairly low, at least as of now in our community. And we need to counsel the family members regarding, because there is no vaccine which is in practical use, because that is the next question which every patient asks. So we need to counsel the relatives in that younger daughters who are, as soon as they become, say, 35 years of age, they have to undergo, and all the family members, female family members, must undergo a mammography starting age 35 with regular breast examination.
Okay.
So these are the things we really need to highlight.
Right.
As far as awareness is concerned.
Thank you so much, ma'am. Talking about vaccines, like Prachi ma'am has just touched, Tanushree ma'am, there is a lot of talk about vaccines, HPV vaccines for cervical cancer. And could you clear the myth controversy around it, when to take it, not to take it, whether to take it, who should be taking it? And also, along with that, are there other preventative measures that one can take? Because there are a lot of female physicians, other females who have joined in today, that they can do when it comes to gynecological cancers. And another question which has come to my mind is, because we talk about oncofertility, but at the start you also said that these cancers are seen in much later age group. Now, how do these two things coincide? So, yeah.
So first of all, talking about cervical cancers and the vaccines that are available. So we have 3 vaccines available in India. So one is a bivalent, another is a quadrivalent, another is a nanovalent. So recently Gardasil 9, which is active against 5 subtypes of HPV virus, is now available in India. So I would definitely recommend that, because we know more the HPV subtypes we are addressing, it's better. So presently the guidelines say that it should be administered within the age group of 9 to 25 years. So if a girl is less than 15 years, so only 2 doses of vaccine are sufficient. And if she is above 15 years, then we have to administer 3 doses. Up till 25, usually it is recommended. But per se, I would not suggest that we should deny any patient. It's basically on the basis of that the sexual function starts usually after that age, and once it started, then there is a chance that she is already affected with HPV. So these vaccines are basically prophylactic and not therapeutic. So that is why usually after 25 you say the benefit would be less. But there are also studies which have shown that as compared to natural immunity, the vaccine induced immunity is higher. So even if a lady wants to take, I would not deny it, but of course telling her that the benefit would be less. The incidence of serious side effects and per se major events have not yet been, definitely diagnosed, reported. So yes, I would suggest that a vaccine should be taken. Second, the thing that you asked about oncofertility in late ages. So although we see that with age, the incidence of gynecological cancers increase, but there are certain definite subtypes which occur in younger patients. And if you look at the incidence of cervical cancer, as much as 1/3 patients are less than 40. And recently, as I said, because of the changing socioeconomic status, more patients are coming as nulliparous. That is, they haven't yet had a single child. So the scope of oncofertility is increasing. Again, certain tumors in ovarian cancer, for example, germ cell tumors, borderline tumors, they occur in younger patients. So there is a lot of scope. Again, endometrial cancer incidence in developed countries is increasing because of the changing lifestyle. Obesity, hypertension, and diabetes are risk factors for endometrial cancer. So definitely these can occur in younger patients also. So there is a lot of scope to oncofertility. And in these patients, it's not necessary that we chop up all the uterus, ovaries, all the organs. Even for cervical cancers, we have now surgeries like radical trachelectomy, wherein we just remove the cervix and the adjacent parametrium, and the uterus and both the ovaries are conserved, and she can have children. And there is a lot of evidence built up in this way. And even for germ cell tumors, you don't need to remove other ovaries. So it's not that more the better.
Right.
It's very important to understand what she requires and give it to her. The patient feels that if I remove everything, I would be safeguarded. That is not the thing. Even if you remove everything, she can recover. So that is what she needs to understand, that the right surgery is important, not the complete.
Most radical one.
So that is one thing. But of course, there are incidences wherein there is no scope for fertility preservation, and still because so that decision has to be taken by the clinician and not the patient.
Okay.
And one more thing I just wanted to add, last thing. Madam just said about hereditary. So it's very important that now we have evidence that almost 15% of ovarian cancer patients will have genetic predilection, which is very, very big thing for at least for ovarian cancer, where we have an incidence of 1 in 100 females. So every ovarian cancer patient should undergo, of course, I'm talking about epithelial ovarian cancer, a genetic testing, particularly BRCA. And even in breast, we are coming up with younger patients to do BRCA because we can safeguard them from ovarian cancer. And if ovarian cancer patient is there, we can safeguard her from breast and her family members from future cancer. So I think hereditary genetic testing is very important in these patients.
Yeah, thank you so much for those commenters, ma'am, and clearing the controversy around vaccines. Last question for you, Joyita, ma'am, before we take from the audience, is we commonly hear this in pop psychology and movies and otherwise that, your mindset determines your treatment response. But in clinical studies or in your clinical experience, do you think that the psychological factors, resilience, has any output in the cancer prognosis, cancer recovery, treatment? What has your experience or studies been around that?
Thanks. So there's a lot of such thinking which had happened at the beginning, when psycho-oncology as a discipline started. So for survival, if you're talking about, I'll talk about treatment outcomes later. For survival, there were a few studies which said that metastatic breast cancer patients who underwent a particular type of psychotherapeutic technique called supportive expressive group therapy had better survival. But then on very detailed minutiae of the data, I don't think that has I don't think that has any strength. However, so survival, that way lifestyle factors will have a role at the onset, about beginning of a cancer maybe, and then if there are problems, it will sort of worsen the outcome because the cancer treatment etc are affected. So if I am depressed, I will not be adherent to taking the medication. I will not take the medication. I will not come for follow-up. I won't do this. If I am anxious, I don't want to get into the MRI. I don't want to get into the surgical table, etc. So it is by way of an indirect way that it might affect, and especially people with depressive disorders, probably diagnosed depressive disorders. How it really affects is by coping. So if you do have, so in the early stages, things like, acceptance and, positive coping strategies will help. But when it is sort of to the later stages, it is recurrent, advancing, palliative care, that time. So in the beginning, fighting spirit as a process always helps. But in those stages, fighting spirit will not. That will just be a deterrent to a genuine acceptance, and then coming, and there's a lot of meaning and purpose in life and existential questions that come through. And those, if you have good, healthy, not good, adaptive or healthy coping abilities from before, so you're expected that you will be able to cope better with this, with good social support, with good medicine, with good clinical practice, that way. And the opposite with this maladaptive, if we abuse drugs, if we don't look after ourselves, we get beaten up every day by the alcoholic husband and have breast cancer and can have to have treatment, that's obviously going to be having a poor outcome. But direct outcome on survival, I don't think any sort of studies have proved that. A lot of we have said, but one point that we should think about is cancer is a family disease. So it is not just about the patients, it's also about the caregivers. So in our plan, we need to have some kind of plan for the caregivers as well, as far as psychological support is concerned. And somebody asked on the question, sorry, I'm going to answer this now because I don't want it to go on, is that when should a person get counseled? So we have our own resilience. Everybody has their own resilience. So the thing is that we cannot forcefully counsel. Okay, we have to go and talk to everybody. Oh, how does that make you feel? You've got cancer diagnosis now. We have to let the person process it in their ways. And if there is a problem, we step in. So 100% counseling is not mandatory, which people forget, because that gives them the time to come to terms with their diagnosis, accept, etc. And then we step in if we have to. And this is wherein training comes in. A lot of people want to help the breast cancer patients by virtue of their relatives having had cancer, of them having cancer. So we go by our subjective experience. We need to be objective. We need to be trained so that we know the boundaries, what the boundaries are.
Ma'am, speaking of training, there are just 2 audience questions, and I think both of them are directed to you that we have right now, because I think we've got a lot of information from the oncologists. So more psychiatry related. One is, what are the current commonly used anti-cancer drugs that are prone to cause psychiatric manifestations? Would all 3 of you could answer those? And another is, in your clinical experience, how does one decide who needs to be called first for a recently diagnosed cancer patient, a psychiatrist or a clinical psychologist?
Okay, so the first question, the ones that we use for breast cancer, the chemotherapy agents or the targeted agents or all that we use along with that and surgery, none of those drugs will really cause anything as, psychosis or depression or anything like that. Delirium can happen post-surgery for anyone, especially for those with those who are older, hospitalized, etc. So I don't think for these. If you ask me about head neck cancer patients, bone soft tissue cancers, then there are some of the drugs that will be affecting, and there could be some neuropsychiatric effects. We've not talked about chemo brain. And that is what is for the chemotherapy related sort of cognitive impairments that patients can go through, which the cause is really unclear. It could be fatigue, it could be chemotherapy related, it could be depression, anxiety, etc. And it may improve later on. But patients have it is a concept because patients do talk about it and survivors do talk about it. So that is why we need to take it. It is what the patient says that is important to listen and hear. So that is one thing that we had not touched on. And what do we have as resource? If you have a psychiatrist, the psychiatrist is the person. If you don't have a psychologist, if you don't have a psychiatrist, you have only a psychologist, the psychologist is the person to refer to. However, there should be an avenue of further referral. So somebody who is not improving, having moderate to severe symptoms, having suicidal ideations, there is some delirium. These are the things that psychiatrists need to be brought in, and a lot of them, not for breast and gynecological cancers maybe, but chemotherapy related side effects can happen, and a lot of it can be steroids because we've been giving them during chemotherapy. All that can happen. So depends on who you have. If there is nobody but the psychologist, of course you have to refer to a psychologist. But psycho-oncology is again an interdisciplinary field. So
Right.
there has to be psychologists, psychiatrists, nurses, social workers, people who are in mental health. They have to be there.
Right. Because of paucity of time, I'm sorry, I can't take any more audience questions. We just have a minute or two left for our chairperson, Dr. Sudhir Bhave sir, to give his summarizing comments before we close it. Yes, sir. Sir, you're on mute, sir.
Yeah.
Yes.
Okay, quick question to Jayata. I mean, how strong is the evidence that psychological factors are there in the causation of malignancy? Maybe a brief answer.
So these are some of the old thinking about psychological factors, especially stress, where we always said that stress will lead to, but it's not the psychological factors, it is the behavioral factors which will predispose to some of the lifestyle choices, which might then predispose to cancer. And the simplest thing being head and neck cancer. So alcohol use, substance use leading up to continuous. So a lot of the behavioral factors we can do something to prevent. Psychological factors, that there is depression, there is anxiety, there is stress, and hence that lead to cancer. I don't think there is evidence for that anymore. That was a lot of the previous old thinking, no longer that.
Okay. So books like Burmese Seagulls, which are, bestsellers, they talk of those kind of issues. Right.
So I don't want to get into that. I am going to talk on whatever is the available evidence at the minute. You know me, sir. So, and I'm sure everybody knows me. Everybody knows that about me, that I will just base it can happen. I'm not saying that it won't be this, but then there has to be an evidence base for that. So we can continue the research and then find out. So that could be, but psychological factors, maladaptive coping styles definitely will affect the treatment outcomes. But that it has led to cancer, I am not sure. I will not go out on a limb and say that.
Sure. So thanks a lot. Now I must say it was a wonderful session. As Jayata alluded to earlier, it's a multidisciplinary field. And I think it was a wonderful idea to have surgeons, oncosurgeons, and psychiatrists come together to talk of the various aspects of management of these patients. And I think it was a wonderful learning experience, I'm very sure, for all those of us who are online right now. And I would especially thank and appreciate Abha for finishing in just in time, because these kind of panel discussions go on and on, half an hour, 45 minutes, and people start leaving slowly one by one. So I think that was wonderful, Abha.
Thank you so much, sir. Yeah, thank you. That was one mandate that I really wanted to make sure I hit. And
yeah. Over to you, Abha.
Thank you so much, sir. I take this opportunity to thank all our esteemed panelists and our chair, Dr. Bhave, sir, who have joined us today, given us this valuable time. And I'm really, truly thankful that everybody agreed to be here on such short notice. This whole thing has been planned and executed in literally a week's time. And all of you have agreed. Because of the holidays, I can imagine that we have had less audience, but whoever has spared their time and audience, I'm glad that you guys are here, and this will be uploaded on our YouTube channel so that more people can get benefit out of this. And I hope in the future also we get to do a lot of these interdisciplinary learning sessions here. Yeah, I think.
Dr. Abha, can I make a comment?
Yes.
Yeah.
So,
myself and Dr. Meenakshi, madam who's the advisor, and myself as the chairperson of the committee, we just wanted to congratulate Abha, because Dr. Abha, as the convener of our section, has done a great job in organizing this program, and we all applause for her wholeheartedly. And it's thanks to all the esteemed panelists of this program today, and thanks to the chairpersons as well. And above all, Abha, we as a team from the IPS Women's Psychological Health really appreciate all the efforts that you did. Thank you so much. Bye.
Thank you so much. Very good night. Thank you so much, ma'am, for those kind words. A very good night to everybody, and a happy new year to all. Hope you have a great time ahead. Thank you.
Thank you.
Bye.
Thank you, Doctor. Thank you, Doctor.
Good night.
Thank you.
Good night. Yes.
Good night. Thank you, ma'am.